Thank you very much. Although I've been to India many times, this is the first time I've been to Coimbatore, and I appreciate the hospitality and the immense amount of work that the organizing committees have done. To be greeted by elephants and a band as you walk into a meeting, this outdoes anything I've ever seen in any meeting, in any conference, worldwide. What I'm going to do is review ophthalmic gene therapy, and I'm going to bring you up to date. Some of this has already been reviewed and discussed by Dr. Natarajan, so please forgive me if there is some duplication. I have to give you a disclosure. I do not have any financial interest in any of the manufacture of genes. Right now, medical therapy is at the level that computer engineering was back in the 1950s, 1960s. There was a lot of work that's being done in medical progress, in pharmaceuticals to treat bacterial, viral, fungal infections, to treat various disorders, inborn disorders. We're at that level right now where we just have some drugs. They're blanket type drugs. In many ways they work, in many ways they don't, but they're not specific for the individual. So right now we're inefficient, just like the old IBM computers. They were good for their day, but compared to what we have now, they're quite inefficient. When the silicone chip came out, it revolutionized the computer industry, our ability to mine data and to have it easy at our fingertips, either with a laptop or even the cell phone. That's our little portable computer that probably gives us as much information in a small package that whole room full of computers and personnel had back in the 1950s and 1960s. So what took place? What is taking place right now? CRISPR. CRISPR is the future. Does anyone know what CRISPR is? Well, you're going to find out now. CRISPR is the clustered regular interspaced short palindromic repeats. Now, what the hell is that? Well, a palindromic repeat is a double-stranded sequence of DNA in which the order of nucleotides is the same on each strand, but they run in opposite directions. So this is going to be the basis of future genetic therapy. Now, each repetition is followed by a short segment of spaced DNA, a plasmid or a virus. We'll go into that later. On top of that, we have the Cas, CRISPR-associated system. It's right next to the CRISPR sequences. What are these? They are molecular scissors to cut or repair the DNA. Now, we have a special version that can edit the genome. It enters a cell together with a synthetic guide using GPS, well, RNA. It cuts the cell's genome at the desired location, and therefore you could have designated genes removed and new ones added. We want to remove the bad ones and replace it with the good genes. So, CRISPR will create double-stranded breaks in the DNA at the specific points. This is new. This is revolutionary because some of the designs before were very inefficient. They were very expensive, like the zinc finger nucleases, which you've probably heard of, zinc finger. The talons, transcription-activated effector nucleases. These required a custom protein for each targeted DNA sequence. It was clumsy, it was time-consuming, and expensive. Well, a CRISPR requires manufacture of only a short RNA sequence. Now, how is it used? Well, biomedicine, that's us. For research purposes, we could create mutations in the human pluripotent stem cell to grow the diseased organoids so that we could study them. We need to have something on the petri dish so that we could study it. That's what it could do. It could give you novel antimicrobial therapy. It could target genes in bacteria that could encode the resistance to some antibiotics. We know about MRSA, and that's another issue, another subject about the genetics of MRSA in the bacteria. We know about other resistance in bacteria. Vancomycin is becoming bacteria getting resistant to that. We can now individualize cancer treatments by repairing muted cancer-causing genes. At least that's what we want to do. We're not there yet. And of course, as I mentioned, we could delete a gene that could interfere with the immune system's ability to fight cancer. This is what's coming. We're not there yet. Okay, now the controversy, germline modification. Can we now work on embryos if we see there's a deficiency genetically in an embryo to replace it, correct those mutations before birth? Well, we could also create new species, bright people, or people that could become future ophthalmologists in all the generations. That's social Darwinism in a genetic modification. So how does this work? Change the DNA software and change the species. That was Craig Venter, who's in San Diego and has been doing this with various types of microorganisms. So what are the digitals for us? Purines, the adenine and guanine, and the pyrimidines, thymine, and cytosine. These are the 4 bases of all life. You change the sequence, you replace any defective gene with this. It's a computer. You can do it. And here we are, converting the analog genetic code into a digital code, right here. Now, in molecular therapeutics, we have 2 different paths. We've got the genome sequencing and tissue engineering with stem cells. You can read it up here. You can see what it is. Our topic today will concentrate on genome sequencing and identification of the mutant gene, and also DNA gene replacement. Of course, the most famous genetic disorder that we've been talking about is the RP65 retinal dystrophies. Now, these are biallelic RPA mutations associated retinal dystrophies, in which you have mutations of both copies of the RPA gene, and it's diagnosed with genetic testing. The next generation sequencing, here's a laboratory that does it. You can see what it's like. It's fairly inexpensive to run now. They could read 300 billion bases per run. This is the next generation sequencing that was previously alluded to. So let's take a look at the different RPE65 retinal dystrophies. I did highlight Leber congenital amaurosis for a certain reason and retinitis pigmentosa at the top. This was previously discussed. I'll discuss it further. We also have severe early childhood onset retinal dystrophy, or CCORD, early onset retinal dystrophy, and early childhood retinitis pigmentosa. Okay, so for those that are not totally familiar with it, we know that these dystrophies, the signs and symptoms of night blindness, usually occur before 95. You get nystagmus, prolonged dark adaptation, diminished visual fields, and severely reduced or undetectable ERGs. Aha! Can we cure this? Can we treat it? Luxturna. Luxturna for Retigene Neparvarak was approved 2 months ago by the FDA. It's an AAV2 vector that has the RPE65C DNA. This was alluded to by Dr. Natarajan in his opening lecture. This was developed by Spark Pharmaceuticals and Children's Hospital of Philadelphia and approved just 2 months ago for Leber congenital amaurosis and retinitis pigmentosa. For this, the patients must have viable retinal cells. Here is the vial. Wow, look at the price tag. $850,000. I won't ask you how many lakhs that is. Now, it's broken into 2 parts. It's just one treatment. It's a one-time treatment. Each eye will get an injection, and that would be $425,000 for each eye. Now, no one can really afford it unless it's a billionaire. It's what we call an orphan drug. But there will be financial manipulations with the manufacturer, with insurance and everything, that will reduce the cost to the family of that individual. But this is what it is. It's diluted, injected in the eye, goodbye. You're cured. Well, that would be nice. It's based on the intravitreal AAV stereotype 2. Dr. Natarajan talked about some of the others, like 8 being developed also for retinal disease, but right now we're at 2. Let's go into gene therapy. These are vectors, usually viruses, that have been genetically altered to carry the normal human DNA to deliver a therapeutic gene to the target cells. And as I mentioned, scientists are manipulating this genome to remove the disease-causing genes and insert new ones. And this is a sequence of it going into the body, gene therapy using an adenovirus vector. Okay, you could give it intravitreal, but there are problems with intravitreal. It doesn't really penetrate the internal limiting membrane of the retina, and you only get about a 10% success intravitreal. What about subretinal? If you give it subfoveal or in the retina, you run the risk of getting retinal atrophy. So instead of improving it, you're hurting it. So what is needed is a type of carrier that could be given both intravitreal and penetrate the internal limiting membrane, given in the periphery so that it's absorbed into the retina without causing atrophy of the critical sites. That's what's being worked on, and this is in the periphery. And here's the mechanism. We have the little DNA genome. It's caught by the capture areas of the cell membrane. It penetrates into that in a little carrier, and then it will transduce into the nucleus. But to have a change now, you have to have 2 different DNAs to work. We're trying to work it with just 1 DNA, but right now it's 2. And then your new protein is manufactured. That's for the retina. Let's talk about glaucoma. Glaucoma still is a problem. This is what's been worked on, different types of vectors to penetrate the trabecular meshwork so that the aqueous could get to the collector channels. What are the problems? We're not there yet. Let's look at the problems. Here's the potential vectors. I showed you the vectors, but here they are. The non-viral, this is just an outline. The naked DNA plasmid, interfering RNA, and the chemicals. We'll go into this. And then we have the viral, the herpes simplex, the adenovirus, adeno-associated viruses. This is one that's really working, the AAV. Please understand there's a difference between the adeno-associated and the adenovirus. And finally, the lentiviruses. I'll go into this in a little bit more detail. Let's go into the non-virals. I mentioned the naked ones, or plasmids. Very temporary effect because the DNA is not integrated into the host chromosome. Then we have the interfering RNA. Now, this could silence the expression of deleterious genes of a known sequence. And we have the short interfering RNAs. And the testing shows that it could inhibit targeted genes, myelin, the myok, that we see in glaucoma. And we have the chemical, the liposomes, that could transfer genes just in cell culture. We're not there yet. The virals. I did mention the adenovirus. These are intermediate-sized, non-enveloped DNA viruses, so it's easy to express. It can get into all types of cell nuclei. What are the problems? Severe inflammations. And we get high neutralizing antibody titers that could limit its effect. We have the herpes simplex, large enveloped DNA. These have envelopes around it. And they could go into the trabecular meshwork, the ciliary body nuclei. It's transduced. Problems, inflammatory responses, cytotoxicity, and a limited effect. Let's go to the virals. The adeno-associated viruses. Okay. We have both the replication deficient virus that may or may not require a helper of an adenovirus. It gets into the host genome. It's transduced. What are the advantage? We don't have any